Yeah, we move on to recurrent endometriosis. Endometriosis is a common condition in the reproductive age group. Surgery, of course, can relieve the symptoms, and endometriosis recurrence rate remains something which a patient is at risk. And the reoperation rates following endometriosis has been quoted as roughly between 28 to 58 percentage. Already told, the types of endometriosis are either it could be a superficial endometriosis, or it could be an ovarian endometrioma, or it can be a deep infiltrative endometriosis. So what are the recurrence rates in these three types of endometriosis? And superficial endometriosis, patients suffer from pelvic pain, whereas endometrioma and DIE, generally they have heavier symptoms and more serious long-term consequences and more difficult to manage. When you look at this legend, you find that at the end of 30 to 36 months, nearly that is an optimum time where these three types of endometriosis, the recurrence rate is almost around 50 percentage. So it is not uncommon for endometriosis to recur after surgery. But the most important thing, you are pardoned if you do a single surgery. But if you do repeated surgeries for endometriosis, this is one of the things which you have to avoid. The recurrence could be as the patient coming back with pain, or it could be the endometriosis being diagnosed in ultrasound or laparoscopy, or it could be when you are treating for infertility, you find that the recurrence has already come, and this increases over a period of time. What's happening to this? It's all deviated to one side. It's okay over here. So the patient is worried about recurrences because the patient usually tells you whether it was due to an incomplete treatment or whether it was due to the regrowth of the condition. So it could be either of these, and persistent or recurrent symptoms following surgery usually have a complex background. Lee et al. In a series of 285 patients reported recurrence in a period of 36 months of time. It was clinically detected when patient had bilateral endometriomas, and when examination showed tenderness and nodularity in the cul-de-sac and had a high revised AFS scores and younger age. All this group of patients are at a high risk of recurrence. Resolution? You want to change? Just waiting for them to change the resolution. So this cystectomy technique already has been repeated by Ashwin, Dr. Malaraj, by injection of vasopressin into the, previously we used to inject vasopressin on the fundus of the uterus. Nowadays we have stopped injecting into the fundus in case of cystectomy. And we usually do our ovariolysis, drain the chocolate cyst, wash it well, and try to inject just below the cyst wall, between the ovarian bed and the cyst wall and trying to elevate the cyst wall. And I'll just get through this faster. So that is why elevation of the cyst wall by injecting dilute vasopressin, you find it balloons out and helps in separation of the cyst wall from the underlying ovarian bed. And things become much more easy, and you find that the bleeding also is much less, and the use of cautery is also minimal. So cystectomy follows, followed by coagulation of the bleeding points. And if you feel that it is wide open and prone for adhesion formation, you think about doing a subcortical suturing. And most important thing, instead of pulling and tearing, it's a dissection technique which you have to follow. And of course, you do find few andral follicles stuck to the cyst wall. Invariably, it is going to happen. You are not going to prevent that thing, but you can minimize the loss of ovarian follicles by doing a cystectomy. But the bleeding definitely is much less, so the use of cautery is definitely less, and you can send this material for histopathological examination. Liu et al. Followed up 710 patients after endometriotic surgery after an average of 22.4 months. The authors defined that the term of recurrence could be endometrioma occurring after 2 consecutive menstrual cycles or with the appearance of the pain. So this could be the 2 symptoms where the recurrence can happen. And in case of severe endometriosis, you find the recurrence rate is much higher. Here you find that both ovaries are adherent behind the uterus, and the uterus is stuck to the uterosacral ligament. The principles remain the same. You do an ovariolysis, and this was the technique which we were using previously. You just drain the contents of the chocolate material, and after that go for a cystectomy. And the most important thing, posteriorly you find the POD is completely obliterated. So you can ask your assistant to do a good anteversion, and you find stretching itself helps you to separate the rectosigmoid, which is adherent posteriorly, and right up to the mid portion of the fundus, and separate the rectosigmoid, and help you to coagulate the implants and do a surgery much completely. So whether you give medical options are whether you give medicines for prevention of recurrence, oral contraceptive pills have been used for postoperatively. This helps to decrease the retrograde menstruation process, and it inhibits the proliferation of the lesions. And Massey compared 70 patients who took low-dose OCP for 6 months and non-users after laparoscopic ovarian endometrioma. He found that although the recurrence rate was lower at the end of first year, they became similar at the end of 2 years and 3 years. So it helps to prevent, but long term it doesn't make much of a difference. This review of article by Andrew Sakare, 2021 February, whether endometriosis recurrence could be prevented by giving postoperative hormonal suppression. And he defined secondary prevention as a prevention of recurrence of pain symptoms or recurrence of the disease. And it was documented either by ultrasound or by laparoscopy more than 6 months after surgery. And he compared levonorgestrel LNG IUD versus GnRH agonist, and found that it was as effective as GnRH after short and medium duration of follow-up. So both LNG and GnRH was good enough for a short, medium time duration of follow-up. The conclusion of this paper was you can give progestins, you can give levonorgestrel IUDs, you can give GnRH agonist, which are all initiated in the first 6 weeks after endometriosis surgery. And you find there is a significant reduction in the endometriosis recurrence pain scores at 1 year post-operatively. So medical suppression should be considered, especially when the patient is not seeking for pregnancy. If the woman is seeking for pregnancy, wants to become pregnant, then you can't put them on medical line of management. And all these hormonal agents have been shown to be effective, and the choice of treatment should be individualized. In the scenario, Indian scenario, and the scenario in Kerala, you find not many would appreciate an intrauterine device like LNG IUD to be put in. So you may have to give them oral, or you have to give them GnRH agonist, or even Dynogest. So this slide looks into the radiological or clinical endometriosis recurrence with post-operative suppression compared to expectant management. One group had expectant management, the other group had post-operative hormonal suppression. And you find that all these others, from 2014 Campo to Young in 2019, the conclusion was the patients who received post-operative hormonal suppression were significantly less likely to experience recurrence of endometriosis with a relative risk score of 0.41. So definitely all these authors have proved that So is there any biomarkers for recurrence? We previously used to do CA1D to find out whether there is a recurrence of the endometriosis, especially when you doubt. But a total of 61 women with recurrent endometriosis were evaluated for estrogen receptor polymorphism. And it showed a frequency of these three types of genotypes. And the percentage was around 54, 46, and 0%. So estrogen receptor polymorphism is one of the methods by which you can test for the recurrence apart from your CA125. The other thing which you can do is the COX-2, a rate-limiting enzyme. We know that on the prostaglandin synthesis plays an important role in inflammation and proliferation of the endometriosis. So severe expression of the COX-2 must be a key factor in women with a high risk. So you can look at the COX-2 inhibition enzyme and find out whether the NSAIDs would be a better option to treat these type of patients with a high levels of COX-2 staining scores. So the COX-2 inhibitor also can be looked to find out whether the recurrence rate is high. So as told earlier, the surgical technique, you have to operate for endometriomas only when they are more than 3 centimeters. Don't have to operate for small endometriomas like 2 or even up to 3 centimeters. And already told by Professor Justin Clark, always perform a cystectomy. Just drainage and diagnostic laparoscopy is not going to prevent, it's going to increase the recurrence for this group of patients. And don't go for just electrocoagulation of the cyst wall. You have to do a cystectomy. The safest way will be to go for a minimally invasive without much damage to the ovarian reserve. So looking at the medical therapies for prevention of the recurrence, Chen et al., long-term follow-up, 13 to 24 months, summarized and relevant assessment was for intervention for secondary prevention. And his group found that reduction of the disease recurrence in favor of post-surgical management. Either you can give OC pills, GnRH agonist, and danazol. Danazol is not used nowadays, and compared to no post-surgical. So post-surgically, you give OC pills, GnRH agonist, or even Dynogest, you find that the things are much less with recurrence. This group compared progestogens post-operatively, giving Dynogest in 130 women and levonorgestrel in 72 women, and no treatment also, and confirmed the efficacy of levonorgestrel IUD for post-operative pain control and prevention of recurrence. So post-operative LNG IUD is good enough, but could not make a conclusion regarding the superiority of the levonorgestrel IUD compared to Dynogest. Dynogest is equally effective, especially when you have to control the pain in this type of recurrences. So there was no superiority of levonorgestrel according to this Lee et al. 2018. Coming whether you can give GnRH agonist post-operatively, Sakari et al. And a subgroup analysis, GnRH agonists reported a significantly decreased risk of disease recurrence compared to controls. So you can give GnRH agonist also You can give a deeper preparation for 3 months, or you can give it monthly for 3 months and see the disease recurrence. Whether doing ART in this group of patients, in patients with deep endometriosis, increases the recurrence. Based on 4 case reports and 12 observational studies, the review concluded that if you do assisted reproductive technology, IVF, ICSI in this group of patients, it does not increase the risk of endometriosis recurrence. You can go ahead with doing an ART procedure and you find that the recurrence rate is much less, less. It does not increase the risk of the recurrence rate. What about deep endometriosis? Usage of hormone treatments for prevention of deep endometriosis, the reports are less robust when compared to the long-term administration to prevent recurrence. This review refers a single prospective trial showing an overall recurrence rate of 7% after surgical management of deep endometriosis, and in 500 women after a follow-up of 2 to 4 years. To conclude, I would say that whenever you do surgery for endometriosis, do it once. Occasionally, you will be forced to do maybe more than once, especially when you're dealing with a large endometrioma, rapidly increasing in size or suspicion of malignancy. But don't persist on doing repeated surgeries because you're going to do more damage than doing good. So it's a chronic inflammatory condition with a high risk of recurrence. So you have to counsel the patient. The chances of recurrence is roughly around about 20, 25, even 30%. And clinicians should be familiar with this assessment of the patient. So you have to follow up clinically, laparoscopically if needed, or even ultrasound is good enough. And tumor markers, at present what we have is only CA125. The others like estrogen receptor polymorphism and COX-2 enzyme evaluation is not available or not within our reach. And often you find a multidisciplinary approach would be able to offer surgery, medical treatment, and pain management would be necessary for management of treatment with recurrent endometriosis. So definitely it has got a role to play in the post-operative period to prevent the recurrence, especially when you deal with a patient who is planning to get a child immediately after the surgery. Then the chances is you have to withdraw the post-operative hormonal therapy. Thank you very much for the patient hearing.